And I have a timer now. Not a Swiss timer, but it worked. Yeah.
Chairman. So I think to start, it would be helpful just to remind ourselves of the classification of inhibitors, which is done mainly in terms of molecular weight. So there's the low molecular weight, the small molecule inhibitors, and examples, citrate, molecular weight 189. And this class of inhibitors, mainly chelators, they bind to calcium and reduce the supersaturation, and there's an example. And then there's phytate, a molecular weight 660, also serve as chelators, but also as crystal surface poisons for preventing growth and adhesion, and there we have an example. And then there's the high molecular weight, the macromolecules, and this is mainly a class that's populated by urinary proteins. This is a well-known one, osteopontin. Obviously, for this discussion, the details of the structure is not important. It's just to show us the complexity, and that's 44 to 66 kilodaltons. That's a kilodalton is 1,000 times bigger than the molecular weight that we report for smaller molecules. I'll show that in a moment. And here's another one, uromodulin. It used to be called Tam-Horsfeld mucoprotein, 95 kilodaltons. And so just for comparative purposes, for introduction, uromodulin is 500 times bigger than citrate, and so it's called a macromolecule. So what macromolecules have been associated with kidney stone formation and inhibition? There are many. And here's just a list of 5 or 6. And we see, as we look at this, that the macromolecules play a supposed role in the 3 processes of nucleation, growth, and aggregation, and also, as we're going to discuss in a moment, adhesion. But paradoxically, most of these have got dual roles, and so they act as both promoters and inhibitors depending on the circumstances, which makes it extremely difficult to characterize what role they're making. It varies. And so here are the 2 proteins, urinary macromolecules, that have received the most attention over the last few years. And so I'll just make some comments about these 2. What are their properties? What are the conditions under which they act? And again, I've underlined here the complexity of studying this, because there's studies which show it promotes calcium oxalate aggregation under conditions of decylylation. And if you look at under other conditions, the inhibitory capacity, depends on its own degree of aggregation. So let's just take a look at a model, a diagrammatic model of how Tam-Horsfeld can act as a promoter or an inhibitor of crystal aggregation. In the first diagram on the left, here, all right, you can see it's a sub-monolayer. In other words, it's not covered completely, and there's attractive forces that can result in aggregation shown in the panel below. If you move over to the right-hand side of the diagram, that's complete coverage where those spheres are the macromolecules. If that's the case, then there's repulsion between the crystals, and we get aggregation inhibition shown at the bottom. Very difficult to follow and characterize. Osteopontin is an inhibitor of calcium phosphate and calcium oxalate crystallization. And then in other circumstances, it promotes nucleation. And it depends on the degree of phosphorylation of the osteopontin itself. So there's structural, there's subtleties within the macromolecule that can change the way it's going to react with crystals. So yes, nucleation, growth, and aggregation are crucial steps in crystallization, but one of the approaches to prevent stone formation is to prevent crystal retention. If crystals are not retained in the kidneys, there will be no kidney stones. So if we could find an inhibitor that can slow down or prevent this crystal retention, this would serve us very well. So here's an example of crystal cell attachment and repulsion. So we notice that the outside surface of the calcium oxalate crystals, this is the monohydrate in the top left and the dihydrate on the bottom right. Outside there's a partial positive charge. The renal tubular cells have a partial negative charge, and so there's going to be attraction and adhesion. The idea is that macromolecules can coat the surfaces of these crystals, shown in red, leaving with a negative charge, which would then be repelled by the negative charge on the renal tubular cells. So that's a simple representation, but this is a real mechanism that deserves attention and has, through using powerful analytical techniques requiring specialist technicians who are skilled in doing the measurements and are skilled in making the interpretations. Just to give you some idea, this is here, the first two diagrams are calcium oxalate monohydrate, and the one on the right is calcium oxalate dihydrate. There are different faces that crystallographers classify with these three numbers, and we don't need to go into that. The point for this lecture is that TAM Horsfell increases the growth on one particular face of COM and increases the growth on another face under certain conditions at high supersaturation or low protein concentration. And then, so it increases growth on some faces and inhibits growth on others. This is an impossible puzzle to try and resolve. Here are photographs, micrographs of actual crystals with the faces labeled, and it's the same sort of issues and problem with osteopontin. So I won't go through them, but if we summarize the attachment of urinary macromolecules between the protein and the crystal, remember you want to coat the crystal, it's face specific, it depends on whether you're using the monohydrate or the dihydrate, and it affects growth of specific faces differently. Then for crystal cell, it depends on the urine environment, the nature of the cell surface, and the crystal surface. And the question, which is the topic of this lecture, is can these factors be clinically managed or controlled? Then the modulatory activity of urinary macromolecules. It depends on, in general, the physiological factors, the expression, the urine environment, the presence or absence of defects in the molecular structure, the structural factors that we've spoken about or briefly mentioned there. And again, we ask the question, is it feasible, thank you, that these factors, can we control these? And my comment about all these experiments, it's superb scientific investigation, very sophisticated and subtle, but the challenges are the different experimental models. It's difficult to obtain consistent results. There's the dual nature, counterintuitive findings, large variability in vivo conditions. So my conclusion is that urinary macromolecules do not yet have clinical applications in the treatment and management of kidney stones. And so we need to, as scientists, in conjunction with nephrologists and urologists, how do we increase the concentration of the good urinary macromolecules? How do we manipulate in vivo conditions to optimize inhibitory effects? How do we increase the sialylation of THP, the phosphorylation of OPN? How do you prevent aggregation of these? What about increasing intercrystalline concentrations? And so I end off with this quotation that was made now, 19, nearly 20 years ago. Adhesion of functional groups and binding of soluble additives, including urinary macromolecules, to calcium oxalate monohydrate crystal surfaces are highly specific in nature, suggesting a path towards a better understanding of kidney stone disease. Here's the prediction, and the eventual design of therapeutic agents. 19 years ago, and I'm afraid, when will this prediction become a reality? I leave it to you to decide. So thank you again for your attention.